London. So welcome to all of you to this discussion today, and I'm really excited to get into this topic. So my first question will be to you, Professor Winters. Can you just explain, firstly, how common is breast cancer?
So I'm sure most of you are aware about, the terms that we bandy around, and we're really talking about population risk. And so we say that 1 in 8 women, and clearly that threshold has changed to potentially between 1 in 7 to 1 in 8 women in the Western world will get breast cancer. And in large part, 80% of that is not linked to a particular gene that we refer to as a germline gene mutation. In other words, something like folks may recollect with Angelina Jolie, which could relate to a high-risk gene such as BRCA1 and 2, and now PALB2, which is only 10% of all breast cancers. So in short, we have a population-based risk, and I'm happy to discuss what that means if that comes up or if that's of interest.
Yes, absolutely. Would you be able to expand on that?
So we're very interested now in being able to test women's population risk. And of course, that's going to be a compilation of epidemiological factors, but largely those epidemiological factors are difficult to measure. So we want to go down to really the root of the problem, and that is about, can we assess what has happened in women's genome over maybe decades, over, in fact, multiple ancestral inheritance. And so we talk about things called really sort of messy genetics, and we're talking about changes in the DNA sugar or base pairs, whereby one base pair can change every billion years. And so basically in each of us, our own genome is slowly evolving, and we call this a single nucleotide polymorphism. So it'll be a sugar base that changes in the DNA, and multiple changes over millennia will then affect our predisposition to breast cancer. You will also get similar changes that can occur for colon cancer, ovarian, or prostate. And so people in the past have talked about, being unlucky or it's just bad luck. Well, it isn't. It's about your population genetics. And so this is a test we're going to be able to offer very soon, in fact, within the next month. And it's based also, it's integrated into an algorithmic process whereby it includes breast tissue density, as well as other key indices that influence breast cancer risk. And basically doing a test like that gives you your lifetime personal breast cancer risk.
Wow, that's amazing, and such an advance from what has been available before. Are you able to expand a little more on this screening process and what those sort of latest diagnostic techniques include?
I mean, the fact is, the French have validated this, but of course you've got polygenic risk scores that are being validated in other parts of the world. So you have Professor Gareth Evans from the Genesis Center, who's looking at 200 over 200 SNPs. And SNPs are just about this polygenic, how you get to the polygenic risk score. So it's like a big gene data set. And what happens is we can do a salivary test, which is just a buccal swab, buccal mucosa. I've done it myself. I'm just waiting for my results. And effectively that gets submitted. You get the result in about 3 or 4 weeks. Then if we look at a mammogram could be 18 months of age. We assess a breast tissue density, and that's based on an assessment of the mammogram whereby breast duct tissue is the white component, fat is the dark component, and it's a ratio of white to dark, and the white is the amount of target tissue. So we bring in that factor. A few other simple questions. You have to be 40 plus years of age, and you have to have not had more than if there's any indication that you're high risk in terms of clusters of breast or ovarian cancer or anything else, you're not eligible for a population test, because testing your BRCA1 and 2 and other multiple genes predominate. So, we're making it very accessible to women.
That's fantastic. Thank you so much, Dr. Winters, Professor Winters. So speaking to you, Dr. Palmer, could you please just explain a little more about what HRT is and how it can be administered?
Yeah, it's Dr. Panter, actually, it's Kate Panter. So HRT stands for hormone replacement therapy, and as it says, as it suggests, this is when you replace the hormones that we lose predominantly at the time of the menopause. So at the time of your menopause, your ovaries stop ovulating and your levels of estrogen fall precipitously. And after the menopause, you'll have a pretty low, stable level of estrogen. But around the perimenopause, you'll have swinging levels of hormone, and that's what causes the sort of hot flushes and night sweats. And hormone replacement therapy is just replacing the hormones that you would have naturally had before your menopause with bioidentical, or we now call sort of body identical copies of those hormones.
Thank you, and sorry there, Dr. Panter. Just another question to you. Could you explain where this sense of taboo has come from around hormone replacement therapy? Why you think that is, and if you think there is any foundation in that?
I think it's a taboo initially around discussion around menopause. I mean, I think the HRT, the taboo about using HRT has perhaps come from women being frightened by the press's sort of approach to breast cancer risk associated with HRT. I'm sure Professor Winter will have a view, but in the press, you think that HRT was the only risk factor for breast cancer. But in fact, it's the same sort of risk as lots of other lifestyle risk factors. And because of that, I think women are quite frightened. They see it as being this huge risk, wherein perhaps obesity is a much greater, more powerful risk factor for breast cancer than HRT. But that's not how it's being portrayed in the media. So I think there are two taboos. The first was actually admitting you were menopausal, talking about the menopause, talking about your symptoms, and having an expectation that we'd be able to help you and sort them out. And the second is then probably the taboo about feeling you failed because you've got to take something to manage something. The menopause isn't a particularly natural state because we haven't really evolved to live past our menopause. There's only us, the orca whales. There's a few mammals that live through their menopause, and so in a sense we're living longer than our bodies are designed to live, and that's why we go through a menopause. And so it's not especially natural to live for 40 years after your menopause. I mean, it's what we do now, but we haven't evolved to do that. So you could philosophically argue that actually replacing hormones we've lost for the last, hopefully 40 years. You go through the menopause at 40 and you die at 90. It's 30 or 40 years of your life is a perfectly rational thing to do.
That's so interesting. I had no idea, or at least had never thought about it in that way, that we're living beyond what historically we were meant to. So that's particularly
and if you think about Africa or some places in the world, you wouldn't actually be living through your menopause. You're naturally likely to die before your menopause. So we are pushing the boundaries of what. So I think that's the other taboo, that women feel they should be able to get through this naturally. They shouldn't have to have any help and shouldn't have to have any treatment.
Yeah, absolutely. But as you said, just as with anything else, replenishing what we need to live healthfully and well is really important for us to live long and happy lives. So on to you now, Professor McGowan. Could you just explain a little more about those risks of HRT and breast cancer? Does it actually increase the risks? And if so, why is that?
Thanks very much for your question. First of all, again, just to highlight the fact that the risk of breast cancer with HRT has been massively, I think, exaggerated by the media, and there has been inaccurate reporting about this risk in the medical press and public media over the past 20 years, and that's why, to some extent, women are scared to take HRT. However, there are some recent publications that do suggest that there is a slightly increased risk of breast cancer risk with taking HRT, and to some extent that will depend on the type of preparation. So, for example, we have women taking estrogen-only preparations. Those are the women that have had a hysterectomy and don't need the combination of both estrogen and progesterone. And the risk, which is increased a little bit more if you do take the combination of estrogen and progesterone. And more recently, also, we have some good indication about what types of progesterones are more likely to increase the risk of breast cancer. Nevertheless, that risk remains, reasonably low, and more recent evidence actually suggests that after stopping HRT or some types of HRT, that risk also tends to regress in time.
And what's the risk associated with past users of HRT? Obviously, you've said there that if you stop, that risk can decrease, but are there particular links between those who have not taken it for a long time, for example, and breast cancer later on?
Yes, so that's a really good question. And again, the literature around this has been a little bit conflicting. And even just a few years ago, a very good publication in The Lancet actually suggested that that risk remained with long-term use. But a more recent NIHR study with over 500,000 women actually provided a bit more reassurance. And this study, looked at about 100,000 women with breast cancer, and which were matched to about 450,000 women controlled. And so it was a good, robust study. And on the whole, the message from this study suggested that there was actually no increased risk of breast cancer with any current HRT taken for 1 year or less. So if we're using it for a short period of time, there's no increased risk. And for those women with a past use of estrogen-only HRT, even if taken long-term, there is no increased risk of breast cancer. If we look, on the other hand, at the combined HRT, which is really taken by most women, if taken short-term, again, 5 years after stopping, there was no increase in breast cancer risk for women who had taken the combined HRT for less than 5 years. Now, if we then look at the long-term users of combined HRT, the good news about the most recent evidence is that risks do actually decline once HRT is stopped.
That's so interesting. And now back to you, Professor Winters. I think Professor McGowan has covered really extensively there the statistics on the risks and between breast cancer and HRT. But I was wondering if this, now that there are more comprehensive studies coming out about those links between HRT and breast cancer, if that will be used to inform whether or not women will be put on HRT in the future after they've had access to this pioneering diagnostic breast cancer mapping that you are currently working on. Oh, you're just on mute.
There we go. So, Bianca, let me just understand what you're asking. Are you asking about women that they've not had a breast cancer diagnosis? How would I work with them in terms of risk and screening? So you're talking about normal women who might come to me in a one-stop setting, for example, at the New Victoria. What am I saying to them based on some of the kind of substantive studies that Barbara has quoted? Is that what you're asking?
Yes.
Okay,
yes.
So I'm a huge protagonist of the fact that our knowledge has evolved in terms of safer forms. So what Barbara has said, what Professor McGowan has said, is that we now have a 21st century approach to HRT. And this is what I say to all women. Now, if you haven't got a uterus, you're home and dry. You can take a transdermal estrogen That may be a transdermal patch, or it could be an estrogel, and you are able to take that for the rest of your life. If you look back at the Oxford paper by Vinogradova, they were looking at older forms of administration that involved tablets. When you take a tablet, it's metabolized through the gut and the liver. You have different metabolites. Being able to apply it transdermally obviates that kind of pathway. You don't have the same risks of stroke and thrombosis. So we have a different application which is safe. Estrogen on its own has potential win-win health benefits. That means an improvement in overall survival, a reduction in dementia, and a reduction in cardiovascular disease. The fly in the ointment comes with progesterone. This is associated, it is not estrogen long-term that is producing the increased risks. Using the older preparations, that gives you 3 to 8 extra cancers in 10,000 women years. So you can literally take it indefinitely. Of course, we have a commensurate modern approach to screening, which in 40-year-olds you might still say is annual mammography, but not every 40-year-old is high risk. So we will offer them the testing I've been talking about with a polygenic risk score. Therefore, we might say, pragmatically, 2 yearly is perfectly adequate. We'll also screen them taking cognizance of density and adding extra modalities that increase sensitivity for picking up cancers, be it bilateral ultrasound, be it breast MRI, if they have extremely dense breasts. So if we come to the majority of women, as Professor McGowan has said, that have an intact uterus, we now need to suppress that lining of the uterus becoming thickened, becoming really having an unopposed stimulation of estrogen. So what is the safest form of progesterone? And I should really defer to my expert panel members, because I'm not a menopause specialist, but I hope that I'm right in reflecting that we would once again either consider an intrauterine administration, an intravaginal administration, or a bioidentical tablet like utrogestan. And clearly that's an individual process, because I've just had women today who have said, their bleeding breakthrough was problematic with maybe a Mirena or with maybe a bioidentical utrogestan. So with the progesterone, with the newer combinations, where in the past we might have thought with that combo we could get 9 to 34 extra cancers in 10,000 women years, we're hoping that with newer forms of 21st century administration, those risks will be lower, and that we also have an increased frequency of breast screening. But I think we should probably ask my expert panel members that same question.
Absolutely. Thank you so much, Professor Winters. So yes, over to you, Dr. Panter. Based on what Professor Winters has just said, could you explain a little bit more about the different types of HRT that are available, and what you might, how you might introduce those to someone who's just about to start the menopause, and how it's decided which one they will take compared to the others?
Yeah, certainly. So in terms of HRT, there are different patterns of HRT administration. So if you're perimenopausal, or if you're within a year or so of your menopause, then you'll need to take cyclical HRT. So if you imagine the ovary, unfortunately, it doesn't kind of neatly stop working. It kind of malfunctions and it works for both and stops. And when you're in the perimenopause and immediately postmenopausal, you need to take cyclical HRT. And what that means is we give you estrogen throughout the month, and then we give you progesterone as well for the second half of the month. And then after the end of the course of progesterone, you'll get a bleed, a bit like you do like a period or like a pill bleed. And the reason for that, if we don't do that, you give people estrogen, they're going to have irregular bleeding. So the first thing to decide on is the pattern. Do you need to be given cyclical HRT, like I've just described, or if your periods have stopped for some time, and your menopause is at least a year or two ago, then we can give you what we call continuous combined HRT, where we give you a little bit of estrogen, a little bit of progesterone every day, and those are in balance, and that stops you bleeding. So that's sometimes known as no bleed HRT. So in a sense, that pattern of administration of hormones is the most fundamental thing. And I guess the Mirena coil, which Professor Winter talked about, bridges a gap, because in the perimenopause, and in fact when we're young, very often we don't bleed at all when we have a Mirena coil in situ. So it's very useful for stopping very heavy bleeding in the perimenopause or at the time of the menopause, because the Mirena coil will sit in the womb, it delivers the progestogen very locally to the endometrium, and it stops you bleeding even when you're a young woman. So that means you can then be given continuous estrogen and you're likely not to bleed. So that's a kind of hybrid. So that's the first thing to think about. What pattern of HRT do you have to have? And once you've decided that, you then decide how you're going to administer the HRT. So HRT used predominantly to be given orally, but it's no longer the case. Now we prefer to give hormones through the skin, because if we start with estrogen, if we give the estrogen through the skin as a gel or a patch, we can give an exact copy of your own hormone. Whereas if you give estrogen orally, it's got to withstand digestion, so it has to be a synthetic estrogen. And then as well as that, Professor Winter mentioned that it goes straight from your digestive system to your liver, and it makes your liver make more clotting products. So there are benefits to having it through your skin. So that's the other thing. Do you give it through your skin, avoid any clotting problems, or to take it orally? So that's another decision. And then that's the estrogen. And the benefits of transdermal, as I said, you don't get any clotting risk and you're getting an exact copy of the hormone. Then the progestogen, which is the other half, it's the other hormone, so you have to have estrogen and progesterone if you have a womb. You can take natural progesterone, so there's only one available. So Eutrogestan is the oral natural progesterone that's available. So that's micronized progesterone. You take that orally, take it at bedtime because it goes to your liver and it helps you sleep. So it's very important to take that at bedtime. But there are lots of copies of progesterone called progestogens they're actually more potent. And actually the variation in breast cancer risk with different HRT relates largely to those different progestogens, as Dr. McGowan was alluding to. Probably the estrogen's the easy part, and actually it's the progesterone that has more risk associated, more different risks associated. And we think that Eutrogestan, which is the actual copy of natural progesterone, is the lowest risk form of the hormone to use. We need more data always, but that's what we imagine from the data that we have to date. So that's not too confusing. So I guess the question you'll have to say is, I say to people, do you feel like applying a gel? So a gel comes, you either have a pump or a sachet, you get the gel out, you have to put it on your skin every day after your shower. So you get out the shower, you dry yourself, you apply the gel to your inner thigh, and then you've got to be patient. You've got to walk around for 5 minutes while you brush your teeth and do other things and let it dry. Now, if you're too impatient for that, then you either have to have a patch, which you stick on your bottom twice a week, change it twice a week. So it's quick to do, but you have to have a little plaster on your bottom all the time. So that's basically the estrogen question. The progesterone question will be more to do with, most people would have Eutrogestan or a Mirena if they're still bleeding. Sounds quite complicated, doesn't it? It's not really very complicated.
I think I've got the gist of what you said there. Thank you for explaining it in layperson's terms. That was very helpful, particularly for me. And are there actually alternatives to HRT that women can take? And is that something that you offer regularly or encourage? What's sort of going on with that?
So there are alternatives. So obviously in some women who've had hormonal cancers who can't take HRT, who are symptomatic, then we would offer a variety of non-hormonal things. So if you start with vaginal dryness, which is often a menopausal problem, they can use non-hormonal vaginal moisturizers or preparations during intercourse. They can use SSRIs, so antidepressant drugs have an effect on hot flushes and night sweats. So in particular, we use venlafaxine because that doesn't interfere with any of the breast cancer drugs. So we very often use that. And then there are other drugs that we can use, which we less commonly offer to women who want a treatment and can take or are prepared to take HRT. I think it's women, when they come to someone like me, have already usually been to a health shop, they've been to Boots, they've tried magnesium, they've tried red clover, they've spent a lot of time and effort on diet and exercise, and they very often are at the end of their tether. So I think, it's often not my role. I think one of the things I do suggest, Mara Hunter, who's a professor at King's, has written a very good self-help guide to CBT for menopause, which I think is really helpful for women to work through. And that helps them think about their symptoms, managing their symptoms, thinking about their symptoms differently. And there's quite a good evidence base that that's efficacious in terms of managing your menopausal symptoms, be it hot flushes, sleep problems, anxiety. And you know that, it's incredibly effective at managing depression and anxiety. So, in a way, it's using that technique to manage your menopausal symptoms. So those are some of the things that we might talk about.
Thank you so much there. And Professor McGowan, on to you. Obviously, Dr. Panter there shared some of the ways in which women typically try to sort of help themselves with their menopausal symptoms before they come to be prescribed something like HRT. But I was wondering, in your experience, what are the most common worries that you see patients coming to you with about taking HRT? What are they afraid of, or what are the most common misconceptions, as you mentioned earlier, that you are very keen to disperse?
Well, by far, women are scared of HRT because of the fear of breast cancer. Sometimes also the risk of clots, but really the majority of women are really scared about this fear of breast cancer. And as I mentioned earlier, a lot of this fear is really not based on evidence. We know that the rates are very small. And it's really about inaccurate reporting about the risk, both by the medical press and the media over the past 20 years. And of course, breast cancer is a common disease. It sort of leads to a lot of anxiety, so it's also understandable. But I think we need to be clear about the messaging, and this is my role is to reassure them and to really go through the benefits of HRT, which are always underestimated, because as mentioned by Professor Winters, there is a cardiovascular benefit, there's a bone health benefit, there's an overall survival benefit. And so really the pros probably in the majority of cases outweigh the cons. But sort of going back to sort of the fears, as I mentioned, 20 years ago, we had research that talked about the increased risk. Then again in 2019, the Lancet, which of course is a very well-respected journal, again showed an increased risk in breast cancer, which was reported to actually remain after stopping the HRT. But we have to interpret studies carefully, really. In that particular study, for example, which was a meta-analysis, included studies which were conducted in different settings, with different selection criteria, with different definition of exposure to HRT. So really, the data were really quite heterogeneous and needs to be interpreted very carefully, really. But the problem was that on the basis of that, the MHRA raised HRT drug safety alert specific to breast cancer, which caused more anxiety. This, of course, has been now questioned, but nevertheless, this is what women are worried about, and therefore it's really important to talk to them, especially about the new HRTs that we discussed. The new progestogens preparation, the Mirena coil, the microgenized progesterone, the Utrogestan, the tablet that we've talked about, because these are much safer forms of HRT, which in combination with the topical preparations or the patches or the gel really probably make that risk of breast cancer much significantly lower than the data with older types of HRT.
Absolutely. Thank you so much. And Professor Winters, I'm wondering if you could explain a little bit for any women who are perhaps worried about this, if there are any overlapping symptoms between breast cancer and what you might expect to experience even if you didn't have breast cancer but have the menopause and are taking HRT. Are there any symptoms that women should be aware of that might be red flags for breast cancer, even if they are going through the menopause? Just unmute you. Oh, hang on a second. Gotta love technology. There we go.
Sorry about this, chaps.
Don't worry.
Gentlemen. Let me understand that. So, the symptoms that women should be aware of in terms of visiting a one-stop clinic that is obviously a triple assessment can be the most prominent thing would be what I describe as a discrete or a perceived lump in the breast. Now, clearly, that is something that is often, it is misperceived by many clinicians and patients because breasts can be complex, they can be very dense, and consequently, part of a one-stop assessment needs to include on the same day, top-notch imaging with expert radiologists. So a breast lump is clearly something that we want women to certainly have a low threshold for referral. Breast pain, if we take hormonal replacement, hormonal replacement therapy can exacerbate a genetic predisposition to breast pain. So you can't say that taking exogenous hormones or even antidepressants that raise prolactin is a cause of breast pain, but 95.5% of breast pain is entirely benign and really is described as a biochemical hypersensitivity of the breast duct tissue, of the cells lining the ducts, and effectively is probably related to one's genome and a benign inheritable gene, but is not linked to breast cancer. So less than 0.4% where we see any abnormality with breast pain. Other key symptoms one should be aware of is any bloody nipple discharge. So any nipple discharge, that could, of course, be exacerbated by HRT because HRT will stimulate the cells, the duct epithelial cells or the normal cells lining the breast ducts to secrete. The breast is a secretory structure. The ducts contain intraluminal secretions. And so HRT, of course, can predispose to cysts if that is also, once again, part of your genome, once again, part of your DNA. It's not that HRT causes cysts, it doesn't. It actually is maintaining a lot of the integrity of that permissive hormonally sensitive tissue. But of course, you can produce more cysts if you're on HRT. If you get any sustained inflammatory change to the breast skin over a period of months with changes where we have edema of the skin, that's a very rare form of breast cancer called inflammatory disease. So in a one-stop setting, we are teaching women how to examine their breasts. We are trying to be very clear about what a lump constitutes. And anything that doesn't constitute a lump, either by assessment of an expert clinician or on imaging, is absolutely normal breast tissue. And so in that context, we're always discussing HRT, and we ask about perimenopausal symptoms. We refer patients to menopause specialists, to experts in the field, and Kate and I work a lot together. And of course, we find that a great advantage. If somebody has a very high risk family history, this becomes more challenging. It's more challenging for everybody in the sense if we prove that somebody has a high risk gene, it seems counterintuitive to therefore say we would be as easy about HRT, but then it becomes a balanced management depending on the type of gene, of course, because in some cases we're going to offer risk-reducing surgery and we offer oophorectomy. So those cases are difficult. In the case of BRCA mutations, a physiologic hormone replacement is not a contraindication. And I think, I'd appreciate Barbara's opinion on that, or Kate's, but we would obviously be doing that in a very managed way between a menopause specialist and ourselves. And in a case where we do offer risk-reducing surgery and oophorectomy, clearly we're making that woman intentionally and surgically postmenopausal. So, there's certainly, from my recent recollection of papers on the subject, it's not a contraindication to HRT. And yet there's always been a reticence about giving such women HRT. But I believe that the current consensus is that it's not a complete contraindication. I'm not sure if I've totally answered your question, if that's what you were looking for, Bianca.
Yes, that was really helpful. I think particularly those symptoms that you mentioned that are suggestive of possible breast cancer, but that also could just be because you're experiencing menopausal symptoms and taking HRT. So yeah, that's helpful. I wonder, Dr. Panter, if you might just expand on what Professor Winter said there, and she said she was looking for to see, what your thoughts might be on that topic as well.
You're on mute, Kate.
Right. Yeah. So in women who've had a prophylactic oophorectomy to reduce their risk of ovarian cancer, you would, on balance, give them HRT until at least 50, the average age of the menopause. Now, some of those women, correct me if I'm wrong, but I think some of those women will have just the oophorectomy and may later then have a mastectomy, but certainly we would give them HRT until the average age of menopause. And that's because, pretty much doctors don't agree on most things, but we all agree that women who go through the menopause before 50, 51 should be given HRT until the average age of menopause. And that's because if you don't replace the hormones, they start to undergo all the changes in their cardiovascular system, their bones, they undergo those changes very young. And we all agree that we should give them hormones until they get to the average age of menopause and push back the point at which those changes will happen. And that includes women who've had a prophylactic oophorectomy.
Right. And so just on that point, could you just expand on, obviously the role of HRT, as the name suggests, is hormone replacement therapy.
Yeah.
But you mentioned there that the goal is to ensure that women who are experiencing menopause, say from 40 until 50-ish, when it's more common age to experience it, that your aim is to keep them on it until that time. So is the ultimate goal to wean women off HRT, or is it a short-term drug that is taken, or is it something they take for life, or does it depend on the woman?
You cracked it at the end there, so it depends. Really, our emphasis these days is on individualising care. So if you're someone who's had your ovaries removed, or someone who's gone through it, we're going to use the hormones to the menopause, and then at menopause time, you're going to decide, like anybody else, whether you then carry on or not. Basically, if you're going to take HRT, the maximum benefit and the fewest risks are to start it early, to start it around the time of your menopause. So there's no benefit to your risk-benefit, analysis to trying to do without it for 5 years and then cracking. If you're going to take it, you get most benefit and least risk starting it early. Because what happens is you stop the changes in your cardiovascular system, in the intima, you stop having the build-up of fatty plaques, you stop your bones thinning, you stop the menopausal changes from even beginning, and then you displace them back in time. And obviously, philosophically, you have to decide, am I going to carry on with this or I'm going to stop it? But you basically displace in time the beginning of those changes if you stop it later. And women will make different decisions. Clearly, it's easier to decide to stop HRT if when you take a holiday, i.e. you reduce your dose and gradually come off it, if you feel well at that point, then it's easier to decide to stop HRT. And the vast majority of women have acute symptoms while their hormones fluctuate and in the immediate few years after the menopause. And a lot of women after that will no longer have hot flushes and night sweats, anxiety, all of these sorts of problems. But they will nonetheless, once their estrogen level falls right down, if they don't take HRT, the low estrogen will affect their bones, their cardiovascular system, in a way more initially silent problems. So I guess we have to make our own decision, and that's based on our symptoms, it's based on our own medical history, our risk factors, our family history risk factors. And to a certain extent, I think there is a philosophical approach. We know that women who take HRT probably live longer and more healthily, but they have to accept that their risk of breast cancer will be higher. So as we get older, we're more likely to get breast cancer. It's a disease that increases as we get older. So if you're on HRT when you're older, then the two are more able to interact, and the hormones can help the breast cancer, if that's how to explain it, if that makes sense.
Yeah, absolutely.
I can't remember what your question was.
No, that did answer my question. That was wonderful. Thank you. And I now have a question for you, Professor McGowan. Based on what Dr. Panter was just explaining, there's a lot riding on women's history of health in their families, etc., their genetic history, and their own personal sort of symptoms and experience of the menopause and how that relates to breast cancer. Something that, thinking as a future patient, I can imagine might be a concern is a feeling that it's all on their shoulders to pick up all these little symptoms and know completely what's going on with everything to do with the menopause and their risk of breast cancer. I was wondering if you might be able to shed some light on how doctors and professors such as yourself working in say specifically menopause and those working within breast cancer communicate with each other to provide a sort of overall holistic care for a patient. So how are those departments communicating together generally to sort of work on this link between HRT, menopause and breast cancer that might sort of help to ease the minds of women who are going to go through this journey?
That's a difficult one. It's a very good question. So the main thing is to try and communicate and clarify the facts for patients. I mean, that's the first thing. And, to explain that, of course, the menopause, first of all, is a physiological change. Everybody will go through it. It's a natural change in life. Explain what actually happens to the hormones during that journey and why women might have such significant changes in mood and symptoms, like the psychological and physical, and it's a very sort of a natural state. And to explain to them that there are things that we can do to help them through that journey. Okay, that's the main thing, and to explain what the options are, which we hopefully, well, not everybody knows how to do well. I think that's the problem, because a lot of, I think one of the questions is, do patients find it challenging because there are so many options, with HRT, but actually also healthcare professionals find it challenging, and not all healthcare professionals know what those options are. So it's about educating, both patients and also healthcare professionals, clarifying the risks of breast cancer as well, and really trying to explain that those risks are actually very small, and we have to individualize care and treatment, but also talk about, like I said, about the benefits of HRT, the benefits on bone health, on cardiovascular risk, and also to highlight the fact that actually a lot of the studies, although they might actually show an increase in breast cancer, they don't actually show an increase in mortality, for example. So that's also something to highlight. But importantly, we have to also talk about, lifestyle factors, which are also important, and perhaps we haven't talked so much about the impact of overweight and obesity on the risk of breast cancer, which of course are much, much higher actually than HRT itself, and of course affect not just breast cancer, but pretty much every type of cancer. So it's really important to talk about lifestyle, the importance of a healthy weight, the importance of regular exercise, the importance of stopping smoking, and all the risks associated with smoking, and of course the risks associated with alcohol. There's a very holistic approach, where we have to address a number of things, and hopefully help them to make a decision and treat the symptoms if and when they come.
Yeah, absolutely. Thank you so much for that. And I have one last question that I would like to put to each of you individually before we finish up today. And so I will start with you, Professor McGowan. And that is, you obviously mentioned there lifestyle being a factor, but is there one particular message, resounding kind of lasting message you would like to give to viewers or listeners of this about the link between breast cancer and HRT, or just one lasting takeaway you would like for them to have?
That the risk of HRT breast cancer is very small and the benefits far outweigh the risk. So please do not be scared to use HRT if appropriate in your particular case.
Thank you so much. And Dr. Panter, same question to you.
I think what I often say to my patients is the studies very often, particularly the recent studies, have focused just on HRT and breast cancer risk. And what I say is if HRT helps you sleep through the night, you get up in the morning, you have a healthy breakfast, you go for a run, you take some exercise, you don't lock yourself out, you don't crash your car, you keep your life together, you're doing your job, you're looking after your children. Actually at the menopause, some of us, our lives fall apart. Some women, they're not coping at work, they're not coping at home. And actually, you shouldn't try and do that without any help. So I think you can't just focus on breast cancer. And as Dr. McGowan says, the risks of breast cancer have been wildly over-exaggerated in the media. What you have to think more holistically is, this is going to help me live longer, healthily. And, I have to look at my risk of breast cancer. And if I'm not in a high-risk group, then I think the holistic benefits outweigh the risks.
Brilliant. Thank you so much. And lastly, to you, Professor Winters.
So just to thank my colleagues, I think it's been great, and I hope that this is going to be something that we can go back to again and again, and it's very exciting that we will start to also dissect out maybe the safest forms of progesterone over and above what we've currently got. If women are concerned, we have a great ability to be able to offer them reassurance with a combined clinical examination and state-of-the-art breast screening on the same day, to be able to do image-guided tissue biopsies and reassure them, also to do tests, as I've described, relating to one's background or population gene risk, which would mean a much more personalized approach to screening, and therefore we can finesse screening in a way that is much more individual and that isn't simply based on a number or age. And I think that's the future.
Brilliant. Thank you so much. So this concludes our discussion on breast cancer and HRT and the relation between them. And so I'd just like to say a final thank you to Professor McGowan, Dr. Panter and Professor Winters for joining us here with Juliet Francis PR today. And we hope you found this discussion fruitful.